You've been handed a prescription, a pamphlet, and a pat on the back. Nobody told you half of what you believe about that pill is pure fiction. Here's everything they skipped. 1. Antibiotics kill viruses. You've believed this your entire life, and every time you've walked into a clinic with a sniffle and walked out with a prescription, the system lets you keep believing it. Antibiotics are molecularly incapable of touching a virus. They were never designed to. Asking for antibiotics for a cold is like hiring an exterminator to fix a gas leak. The professional showed up, took your money, and addressed nothing in the building. Antibiotics work by targeting structures that are unique to bacteria, cell walls, ribosomes, DNA replication enzymes. None of those structures exist in a virus. Viruses are not cells. They are genetic material wrapped in a protein coat, and antibiotics have zero mechanism to interact with them. The Centers for Disease Control estimates that 28% of all antibiotic prescriptions in the United States are unnecessary, and a significant chunk of that is driven by patients demanding them for viral illnesses their doctor already knows the drug won't touch. Every unnecessary course you take kills off the beneficial bacteria in your gut and breeds resistant strains, meaning the next time you genuinely need antibiotics for something bacterial and dangerous, they may not work. Antibiotic-resistant bacteria kill approximately 1,270,000 people globally every year, a number directly linked to overuse and misuse. And here's the part that should genuinely bother you. Doctors often write the prescription anyway, not because it works, but because explaining why it won't work to a frustrated patient in a 15-minute appointment takes longer than picking up the pen. You're being handed a useless drug because declining you takes too much time. That's the actual transaction happening at that counter. 2. You have been told since childhood to finish every single antibiotic pill in the bottle, or the bacteria will mutate into a superbug and the blame will land squarely on you. The rule is stated with the gravity of physical law. Finish the course, every last one. The inconvenient truth is that the entire foundation of this instruction was not a clinical trial, it was a speech. Alexander Fleming, the man who discovered penicillin, warned in his 1945 Nobel Prize acceptance speech about the dangers of underdosing antibiotics. That off-the-cuff warning, delivered during an awards ceremony, became global medical gospel for 80 years, without a single randomized controlled trial to back it up as a universal rule. A landmark analysis published in the British Medical Journal in 2017 by Infectious Disease, researchers argued that for many common infections, shorter courses are equally effective and actually carry less resistance risk than longer ones. Here is why. Resistance does not develop because bacteria somehow learn from your incomplete treatment and regroup. It develops because longer antibiotic exposure creates broader selection pressure, wiping out sensitive strains and leaving resistant ones to dominate unopposed. Finishing a longer course can, in some contexts, do more to promote resistance than stopping when symptoms resolve. For tuberculosis, finishing the full course is genuinely critical. That one is non-negotiable. But for a routine urinary tract infection or a mild skin infection, the science is far murkier than the pamphlet in your pharmacy bag suggests. This is not filtered down to clinical practice. Your bottle still says, finish it all. The rule you have followed your entire life was a footnote in a Nobel acceptance speech from the man who invented penicillin, not a double-blind study. You have been obeying one scientist's gut instinct delivered at a podium in 1945. 3. The story you have absorbed about opioid addiction is that it happens to a certain type of person. Someone with a predisposition, a weakness, a character flaw baked into their neurochemistry before the first pill was ever swallowed. If you are mentally strong, responsible, and not that type, you are safe. This belief is not just wrong. It is the specific belief that the opioid industry required people to hold in order to move product at the scale it did. Opioid dependence is a neurochemical process. Your personality is irrelevant. Opioids bind to mu-opioid receptors in the brain and trigger a dopamine release in the nucleus accumbens, the exact same reward pathway activated by food, sex, and survival behaviors. This happens in every human brain, regardless of how disciplined you are, how responsible you are at work, or how many times you have said you are not that type of person. Physical dependence, where the body adapts and requires the drug to function normally, can develop in as few as 5 days of continuous opioid use. According to research published in the Journal of the American Medical Association, the concept of an addictive personality, while it has some genetic basis, accounts for a minority of opioid addiction cases. The majority of people who became addicted during the opioid crisis had no prior substance abuse history whatsoever. Purdue Pharma explicitly marketed OxyContin using a low addiction risk narrative to physicians, and the company's own internal documents showed they knew that claim was false while they were making it. More than 80% of people who currently use heroin started with prescription opioids, not because they had a predisposition, but because they were prescribed a legal medication for legitimate pain. The coal does not negotiate with your personality, neither does the receptor. 4. The expiration date on your pill bottle is treated in most households like a bomb timer. The morning after that date, the bottle goes into the trash, and you feel responsible and safe for doing so. The expiration date marks the point at which the manufacturer can no longer legally guarantee full potency, full stop. It does not mark the point at which the drug becomes harmful, dangerous, or chemically transformed into something that will hurt you. The Food and Drug Administration ran a program called the Shelf Life Extension Program in collaboration with the United States military, which tested large stockpiles of medications well past their labeled dates. The results found that 88% of those medications remained safe and effective, in some cases by over a decade beyond their printed expiration. A study published in the Journal of the American Medical Association analyzed medications found in a decades-old retail pharmacy and found that many retained close to full potency. There are genuine exceptions, and they matter. Liquid antibiotics, particularly suspensions, degrade meaningfully and should be replaced on schedule. Nitroglycerin, insulin, and epinephrine auto-injectors lose potency in ways that are clinically consequential and should absolutely be current. Tetracycline was historically implicated in kidney damage when expired, though the formulation responsible was removed from the market, and that risk is now considered largely theoretical with modern manufacturing. Here is the part the pharmaceutical industry would prefer you not think about too carefully. They have a direct financial incentive to set conservative expiration dates. Selling you a replacement bottle is more profitable than extending the shelf life claim on the original. The annual waste of medications due to expiration date anxiety costs the healthcare system an estimated $1 billion or more in unnecessary repurchases every year. You have been throwing away functional medication because of a date printed by the company that profits when you buy a new bottle. 5. Brand name drugs feel premium. The packaging is well designed, the name is memorable, and paying significantly more for something feels like evidence that you are getting the superior product. Generics feel like the knockoff, the store brand, the option for people who cannot afford the real thing. This perception is a gap between marketing and regulatory chemistry, and that gap is costing you money for no clinical reason. The Food and Drug Administration requires generic drugs to contain the identical active ingredient in the identical dose with identical bioavailability. The FDA's bioequivalence standards require generics to deliver between 80 and 125% of the brand name drug's bioavailability. And in practice, most generics fall within 3 to 5% of the brand, well inside that window. Many generics are literally manufactured in the same facilities as their brand name counterparts, sometimes on the same production line, with different labels applied at the end of the process. What differs between a brand and its generic is the inactive ingredients, fillers, dyes, binders, and coatings. For a small subset of patients with specific sensitivities, this can occasionally matter. For the overwhelming majority, it has no effect on therapeutic outcome. The price difference is not about quality, it is about research and development, cost recovery. Once a patent expires, the original company loses its monopoly, and competitors can produce the identical compound cheaply. Brand name companies have also repeatedly launched what are called authorized generics, the identical product under a different label, specifically to compete with true generics. That practice alone is proof the products are the same. Billions of dollars in patient spending are wasted annually on brand name prescriptions that could be filled generically with zero clinical difference in outcome. You are paying triple the price for the label. The pill inside does not know what the box cost. 6. The prescription pad is treated as a certificate of personal safety. A doctor wrote your name on it, which feels like the drug has been tailored, vetted, and greenlit specifically for your body, your history, and your current condition. Here's what a prescription actually tells you. A licensed professional, under time pressure, made a clinical judgment that this drug is an appropriate starting point for someone with your stated symptoms. The World Health Organization estimates that medication errors harm 1.3 million people annually in the United States alone, at a global economic cost of approximately $42 billion. Drug-drug interactions are frequently missed in busy clinical settings. A 15-minute appointment leaves very limited time to cross-reference every medication on your current list against the new prescription being written. Genetic differences in liver enzymes, particularly those encoded by CYP2D6 and CYP2C19 genes, mean that the same dose of the same drug can be dangerously toxic for one patient and completely ineffective for another. Most patients are never tested for these variants. A study published in the Annals of Internal Medicine found that nearly 15% of outpatient prescriptions contained a potentially serious error. Off-label prescribing, using a drug for a purpose the FDA has not specifically approved, is legal, common, and accounts for roughly 1 in 5 prescriptions written in the United States. Sometimes that's supported by excellent evidence, sometimes it's supported by very little. Doctors operate within real-world constraints: time pressure, formulary restrictions, pharmaceutical representative influence, and appointment structures that do not prioritize your individual biochemistry. A prescription is a starting point made under those conditions. It is not a guarantee. It is the doctor's best clinical estimate, and your best defense against its limitations is knowing enough to ask the right questions before you swallow. 7. There is a clean mental line most people draw between medication and drugs. Medication comes from a pharmacy with a white paper bag and a receipt. Drugs come from somewhere else entirely. The white coat and the prescription pad launder the transaction into something that feels categorically safe. The molecule does not know it was prescribed. Dependence follows neurochemistry, not paperwork. Benzodiazepines, including alprazolam, diazepam, and clonazepam, sold under names like Xanax, Valium, and Klonopin, are among the most widely prescribed medications in the world and among the most physically addictive substances that exist. Benzodiazepine withdrawal can produce seizures and death, outcomes that are more dangerous than heroin withdrawal in clinical terms. The 5th edition of the Diagnostic and Statistical Manual of Mental Disorders explicitly includes prescription drug use disorder as a clinical diagnosis. The source of the drug is irrelevant to that diagnosis. Stimulants prescribed for attention deficit hyperactivity disorder, amphetamine salts and methylphenidate, sold as Adderall and Ritalin, carry genuine misuse potential and are classified as Schedule II controlled substances by the Drug Enforcement Administration. Schedule times 2 is the same classification as cocaine. Many patients who develop prescription drug dependence do not recognize it as addiction precisely because the drug came from a doctor. They reframe daily craving and escalating doses as medical necessity because the framing of a prescription makes that reinterpretation feel logical. Physical dependence, where the body adapts to continued use and produces withdrawal without it, can develop with antidepressants, sleep medications, and pain medications even in patients who use them exactly as directed. The prescription receipt does not change the biology of what is happening in the brain. A legally dispensed hook is still a hook, and the pharmacy receipt does not rewrite the pharmacology. 8. For 4 decades, doctors across the world have explained depression to patients using the same simple framework. Your brain has a chemical imbalance, specifically low serotonin, and this medication corrects it. It was presented as settled neuroscience. It was clean, it was intuitive, and it gave patients a coherent explanation for their suffering. It was also a post hoc rationalization built on a theory that was never directly proven, dressed up in clinical language, and amplified by pharmaceutical marketing. A 2022 umbrella review published in Molecular Psychiatry, led by researcher Joanna Moncrief and colleagues, analyzed decades of accumulated research and found no consistent evidence that people with depression have lower serotonin levels or reduced serotonin activity compared to people without depression. That review did not argue that antidepressants are ineffective. They help many patients meaningfully and genuinely. What it dismantled was the confidence with which the mechanism was stated. Selective serotonin reuptake inhibitors do increase serotonin availability. But why that translates into reduced depression for some patients remains poorly understood. The chemical imbalance framing was partly popularized by pharmaceutical marketing campaigns for drugs like fluoxetine in the late 1980s and 1990s. It was a simplification designed for consumer comprehension, not a validated mechanistic description. Active competing theories of depression now include neuroplasticity, systemic inflammation, HPA axis dysregulation, and circuit-level connectivity changes, all of which better account for the available evidence. The chemical imbalance myth also carries a documented clinical harm. Patients who understand their depression as a simple deficiency are measurably less likely to engage in psychotherapy or lifestyle interventions that show comparable efficacy to medication. You were handed a metaphor and told it was a mechanism. The pill may still be helping. Science simply does not yet fully understand why. 9. The logic feels airtight. You feel better. The symptom is gone. The medication solved the problem, which means the problem no longer exists, which means the medication is no longer needed. This is a reasonable conclusion for most situations in life. It is the wrong conclusion for antidepressants, and acting on it is one of the most common psychiatric treatment errors made by patients worldwide. Clinical guidelines from the National Institute for Health and Care Excellence, the American Psychiatric Association, and the World Health Organization all recommend continuing antidepressants for a minimum of 6 to 12 months after achieving remission. And that is for a first episode. After a second depressive episode, most guidelines recommend 2 or more years of continued treatment. After a third, indefinite maintenance therapy may be appropriate. Abrupt or early discontinuation of selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors can cause what clinicians call discontinuation syndrome. Electric shock sensations in the limbs and head known as brain zaps, dizziness, nausea, flu-like symptoms, and intense emotional instability. These symptoms are frequently misidentified as relapse, which then causes patients to restart medication and conclude they are permanently dependent. Relapse rates for depression after premature medication discontinuation are estimated at 40 to 60% within the first year. The most important piece of this, the experience of feeling better on antidepressants is partly caused by the medication actively working. Removing the medication removes the therapeutic effect. Patients frequently interpret this as proof the drug was never necessary when it is actually evidence that it was. Stopping your antidepressants because you feel better is structurally similar to canceling the treatment that was producing the recovery and being surprised when the recovery stops. Timing the exit requires a plan made with your prescriber, not a personal assessment made on a good Tuesday. 10. The open pharmacy shelf carries a specific psychological message. If it were dangerous, it would require a prescription. Over-the-counter status means the drug was deemed safe enough for unsupervised use at the labeled dose. Read that again carefully, at the labeled dose. It says nothing about what happens when you exceed it, combine it with other drugs, or take it daily for years because you never questioned whether you should. Acetaminophen, sold as Tylenol and paracetamol and included in hundreds of combination products, is the leading cause of acute liver failure in both the United States and the United Kingdom. Not because it is inherently dangerous at recommended doses, but because it is so universally perceived as harmless that accidental overdose is extremely common. People take it for a headache, take a cold medicine that also contains it, add a nighttime sleep formula that includes it, and never connect the cumulative dose. The toxic threshold for acetaminophen is deceptively close to the therapeutic dose. Non-steroidal anti-inflammatory drugs like ibuprofen, available freely in every pharmacy, carry meaningful risks of gastrointestinal bleeding, kidney impairment, and cardiovascular events. Risks that scale with dose, frequency, and individual patient risk factors. Diphenhydramine, the antihistamine in Benadryl and most OTC sleep aids, is an anticholinergic drug now associated in research with impaired cognition and in newer epidemiological studies, potentially with increased dementia risk when used long-term. St. John's wort, sold openly as a mood supplement, is a potent inducer of a liver enzyme that metabolizes numerous prescription drugs and can reduce the efficacy of birth control pills, HIV antiretrovirals, and anticoagulants to subtherapeutic levels. Over-the-counter is a location on a shelf. It is not a safety rating. Plenty of things that can seriously hurt you are right there next to the checkout lane. 11. The word natural on a supplement label performs a complete moral laundering of whatever is inside the bottle. It's from nature. Nature is good. Nature does not require a prescription or a warning label or any serious scrutiny because it has been around longer than pharmaceutical companies and therefore cannot possibly hurt you. Dose makes the poison. Natural compounds taken at pharmacological quantities are drugs, with drug effects, drug interactions, and toxicity profiles that do not become less real because the source was a plant. Vitamin A toxicity, known clinically as hypervitaminosis A, is a well-documented syndrome causing liver damage, bone loss, and in pregnant women, severe fetal abnormalities. It occurs specifically from high-dose supplementation, not from dietary intake. Vitamin E supplementation at high doses was associated with increased all-cause mortality in a meta-analysis published in the Annals of Internal Medicine, the opposite direction of the antioxidant benefit most users are pursuing. High-dose vitamin B6 supplementation, above 50 milligrams daily over extended periods, causes peripheral neuropathy, a nerve damage condition producing numbness and pain that is frequently misattributed to other causes. Supplements are regulated in the United States under the Dietary Supplement, Health and Education Act of 1994, which does not require manufacturers to prove safety or efficacy before putting a product on the market. The Food and Drug Administration can only act after harm is documented. Third-party testing by organizations like NSF International and the United States Pharmacopeia finds label discrepancies, wrong doses, missing ingredients, contamination, in a substantial proportion of tested products. Drug interactions with supplements are real and clinically significant. Calcium reduces thyroid medication absorption. Iron blocks certain antibiotics, and high-dose omega-3 supplements potentiate anticoagulant effects. Arsenic is natural, so is hemlock. The word on the label is doing all the moral work while the dose does all the biological damage. 12. Cannabis is routinely described, particularly in legalization conversations, as uniquely safe because no lethal dose has ever been established in humans. Nobody has ever died from weed has become a cultural axiom repeated with the confidence of a pharmacology textbook. The absence of a lethal overdose threshold does not mean cannabis is without serious acute and chronic harms, and the clinical definition of overdose extends well beyond death. Acute cannabis intoxication, particularly with high-potency concentrates or edibles, can cause cannabinoid hyperemesis syndrome, acute psychosis, severe anxiety, and cardiac arrhythmias, all of which have required emergency hospitalization. Edible cannabis carries a distinctly elevated overdose risk because onset is delayed by 30 to 90 minutes, leading people to consume multiple doses before the effects of the first dose are felt. Emergency room presentations for cannabis overdose spiked significantly following legalization in multiple states, which is what the data showed would happen. Modern cannabis products have tetrahydrocannabinol concentrations dramatically higher than the plants associated with the historical safety claims most people cite. Concentrates can reach 70 to 90% THC, compared to 4 to 8% in traditional preparations. Cannabinoid hyperemesis syndrome, characterized by cyclical vomiting paradoxically relieved by hot showers, is a now well-documented condition caused specifically by chronic heavy cannabis use. Cannabis use disorder is clinically recognized in the Diagnostic and Statistical Manual and affects approximately 9% of people who use cannabis, rising to 17% for those who begin in adolescence. Emerging cardiac data links heavy cannabis use to myocardial infarction risk, particularly in younger users, through vasospastic and tachycardic effects of acute intoxication. Nobody has ever died is not a pharmacology argument, it is a street testimonial. The emergency room sees the cases that don't make the cultural conversation. 13. Most people treat alcohol and medication combinations as a simple intoxication multiplier. You'll feel the alcohol more, get drowsier, maybe wake up with a worse headache than usual. Inconvenient, perhaps embarrassing, but not dangerous. Alcohol interacts with dozens of medication classes through mechanisms that go far beyond sedation enhancement, and some of those combinations are acutely life-threatening in ways that have nothing to do with how drunk you feel. Alcohol combined with acetaminophen at even moderate drinking levels significantly increases the risk of liver damage. Alcohol induces a specific liver enzyme that converts acetaminophen into its toxic metabolite, and simultaneously depletes the compound that normally neutralizes that metabolite. The combination is not a dramatic multiplier. It is a mechanistic setup for hepatic injury that happens quietly. Alcohol combined with blood thinners like warfarin produces unpredictable changes in clotting. Acute alcohol use inhibits warfarin breakdown and increases bleeding risk, while chronic alcohol use induces warfarin breakdown and reduces its effectiveness. Alcohol combined with metronidazole, a common antibiotic, causes flushing, vomiting, palpitations, and dangerous blood pressure drops. A reaction so reliable it is used therapeutically to discourage drinking in alcohol use disorder treatment. Central nervous system depressant combinations, alcohol with benzodiazepines, alcohol with opioids, alcohol with sleep medications, suppress the brain's respiratory drive. This is a primary mechanism in drug-related overdose deaths. The warning label says, "Avoid alcohol on most of these medications." Virtually everyone ignores it because nobody explains that avoid sometimes means, or your liver will fail rather than you might feel a little woozy at the holiday party. Monoamine oxidase inhibitors, an older antidepressant class combined with certain fermented beverages, can cause hypertensive crisis, a blood pressure spike severe enough to cause stroke. You read the warning as a suggestion. Your liver read it as a directive. Only one of you was right. 14. Past exposure without a reaction is treated as permanent clearance. You have had penicillin before, it went fine, and so you report no allergies to every medical professional you encounter from that point forward. The case is closed, the history is clean, and the future prescriptions are written without hesitation. Allergic sensitization requires prior exposure. The first serious allergic reaction almost never happens on first exposure. It happens when the immune system has already built a response during a prior encounter and then meets the same antigen again. This means you must have previously tolerated a drug at least once before you can develop a classical allergic reaction to it. Prior tolerance is not future clearance, it is the biological setup for future risk. Penicillin allergy is the most frequently reported drug allergy, affecting approximately 10% of the population by self-report. Up to 90% of those who report it can tolerate penicillin upon formal allergy testing. Most historical penicillin allergies were side effects, nausea, rash from an underlying infection, not true immune reactions, but the label persisted in the chart for decades. Drug allergies can also desensitize over time. 80% of people with a true penicillin allergy will test negative 10 years after their last reaction, yet they carry the allergy label indefinitely and are treated as if the reaction could recur at any moment. Carrying an incorrect allergy label has real clinical consequences. Patients labeled penicillin allergic are more frequently given broader spectrum antibiotics that contribute to resistance and are associated with worse outcomes in infections where penicillin remains the gold standard treatment. Drug hypersensitivity can also develop as a delayed reaction appearing days after exposure. Well outside the window, most people would associate with an allergic event. Your immune system's filing system does not work the way you think it does. Prior tolerance is the loading phase, not the clearance. 15. Pain is the problem. Painkillers address pain, therefore painkillers solve the problem. This logic is clean enough that it survived clinical practice guidelines for decades, drove an opioid epidemic that has killed hundreds of thousands of people, and still shapes the expectation patients bring into pain clinics every day. For chronic pain, defined as pain lasting more than 3 months, opioid painkillers frequently become part of the problem rather than the solution, and they are no longer considered first-line treatment in major clinical guidelines. The 2022 Centers for Disease Control Clinical Practice Guideline for prescribing opioids explicitly states that non-opioid therapies are preferred for most chronic pain conditions. This was a significant reversal from the guidelines that helped drive the opioid epidemic in the 1990s and 2000s. Opioid-induced hyperalgesia is a well-documented clinical phenomenon in which long-term opioid use actually increases pain sensitivity. The drug designed to reduce pain physiologically amplifies the pain experience over time, a pharmacological outcome so counterintuitive that many patients and some clinicians still do not recognize it when it is happening. For chronic low back pain, one of the most common reasons opioids are prescribed, a Cochrane review found that opioids provide only modest short-term benefit and significant long-term harm, performing no better than non-opioid analgesics for functional outcomes. Cognitive behavioral therapy for chronic pain has a robust evidence base comparable to opioids for long-term pain management and functional improvement without dependency risk. Physical rehabilitation, anti-inflammatory medications, anticonvulsants for neuropathic pain, and low-dose tricyclic antidepressants all show superior long-term profiles for specific chronic pain types compared to opioids. The neurological mechanism of chronic pain involves central sensitization, a rewiring of the pain processing nervous system, which opioids do not address and may worsen over time. The immediate sensation of doing something is not the same as fixing the underlying problem. 16. There is a deep cultural script around medication and stoicism. You wait until it is really bad. You hold out. You push through until the pain is unbearable, and then, finally, you take something. This is presented as discipline, as not over-medicated, as being sensible about chemicals. Clinically, it is an error that makes the medication less effective and the pain significantly harder to manage. Pain is neurologically easier to prevent than to reverse. The process of central sensitization, sometimes called wind-up, describes how prolonged pain signals make the nervous system progressively more responsive to pain stimuli over time, lowering the threshold for future pain and making breakthrough dosing necessary. You wait until the pain is unbearable, and now you have trained your nervous system to run a more efficient pain circuit. Postoperative pain management research consistently shows that patients who receive scheduled preventive analgesics, dosed around the clock rather than on demand, require lower total medication doses and report better outcomes than those who receive it only after requesting it. The World Health Organization's analgesic ladder, developed for cancer pain management but widely applied, explicitly recommends by-the-clock dosing rather than reactive dosing, specifically to prevent neurological escalation. Severe breakthrough pain frequently requires higher doses to control than the preventive doses that would have stopped the escalation from happening. Paradoxically, waiting longer means taking more medication overall. For migraine specifically, the evidence is unambiguous. Treating at the first sign of an attack with triptans or nonsteroidal anti-inflammatory drugs is dramatically more effective than waiting for the headache to reach its peak. The psychological fear of dependency from scheduled short-term pain medication is not clinically warranted and conflates two separate pharmacological concepts. Waiting until the pain is unbearable is not discipline. It is a delay that makes the pharmacological problem exponentially harder to solve. 17. Herbal products exist in a separate mental category from medicine. They are teas, capsules, drops from a health food store, ancient remedies from before pharmaceutical companies existed, operating in a completely different lane from the drugs your doctor prescribes. The lane is imaginary. Herbal compounds are pharmacologically active, and several of the most commonly used ones carry clinically significant interactions with prescription medications that are dangerous in ways most patients and some physicians do not anticipate. St. John's wort, used widely for mild depression, is a potent inducer of a liver enzyme called CYP3A4 and a transporter protein called P-glycoprotein. It can reduce the plasma concentrations of HIV antiretrovirals, cyclosporin used in transplant patients to prevent organ rejection, oral contraceptives, warfarin, and digoxin to subtherapeutic levels, meaning the prescription drug stops working while it is still being taken. Transplant rejection episodes have been documented in clinical literature directly attributed to patients taking St. John's wort alongside cyclosporine without informing their transplant team. An organ was rejected because of a supplement purchased at a health food store that the patient did not consider worth mentioning. Ginkgo biloba inhibits platelet aggregation and potentiates anticoagulants and antiplatelet drugs. Combined with aspirin, warfarin, or clopidogrel, it meaningfully increases bleeding risk. High-dose garlic supplements similarly affect platelet function and anticoagulant metabolism, elevating bleeding risk in patients who take them in the days before surgery. Kava and valerian can potentiate central nervous system depressant medications, including benzodiazepines and anesthetics. Most patients do not voluntarily disclose herbal supplement use to their physicians because they do not consider it medication. Most physicians do not ask specifically enough to catch it. The same ecosystem that gave us morphine, aspirin, and digoxin also gave you the compounds in your wellness tea. Pharmacology does not care which aisle you purchase them from. 18. Sleeping pills are imagined as a gentle pharmaceutical nudge toward unconsciousness, essentially what melatonin does, but with a prescription sticker on the bottle. A little stronger, the same general idea, nothing to think too hard about. Melatonin modulates your circadian rhythm. It works with your body's existing light-dark cycle to shift the timing of sleep onset. Prescription sleep medications, particularly benzodiazepines like temazepam and triazolam, and Z drugs like zolpidem and zopiclone, work through an entirely different mechanism. They bind to GABA A receptors in the brain and produce sedation through central nervous system depression. That is not a stronger version of melatonin. That is a categorically different pharmacological action. The Food and Drug Administration issued a black box warning specifically for Z drugs after documenting complex sleep behaviors in users. Sleep driving, sleep eating, and other parasomnias that occur without conscious awareness and leave no memory behind. These are not rare theoretical events, they are documented, reported, and serious enough to warrant the FDA's highest warning tier. Physical dependence on benzodiazepine sleep aids can develop within 2 to 4 weeks of nightly use, and withdrawal from long-term benzodiazepine use requires careful tapering. Abrupt discontinuation can cause seizures. Rebound insomnia after stopping is frequently worse than the original sleep problem, which traps patients in continued use they never intended. Zolpidem was approved at a standard dose of 10 milligrams. The FDA subsequently found that morning blood levels in women were sufficient to impair driving ability and required the recommended dose to be reduced to 5 milligrams, a correction that arrived more than 2 decades after initial approval. Benzodiazepines are explicitly listed on the Beers criteria, identifying medications considered inappropriate for elderly patients due to fall risk and cognitive impairment. Cognitive behavioral therapy for insomnia shows equivalent or superior long-term outcomes to sleep medication without producing dependence. Melatonin is a traffic signal. Prescription sleep medication is sedation. Getting those confused is a meaningful clinical error. 19. Thimerosal became a cultural weapon because the logic appeared airtight. Mercury is toxic, thimerosal contains mercury, therefore vaccines contain poison. The chain of reasoning sounds scientific enough to be convincing, and it spread through parent communities with the velocity that fear always achieves when it borrows the language of chemistry. The chain has a critical break. Thimerosal contains ethyl mercury. The neurotoxic form of mercury that accumulates in fatty tissue and damages the brain is methyl mercury, the kind found in contaminated fish. These are not the same compound, and the biological difference between them is not trivial. Ethyl mercury has a half-life of approximately 7 days in the body and is cleared rapidly without bioaccumulation. Methyl mercury has a half-life of approximately 70 days and accumulates specifically in fat-rich tissue, including the brain. The exposure from a single tuna sandwich typically contains more methyl mercury, the genuinely dangerous form, than was ever present in a full childhood vaccine schedule, and that is the less dangerous form compared to inorganic mercury. Thimerosal was removed from all routine childhood vaccines in the United States by 2001, retained only in some multi-dose influenza vaccine vials. Autism diagnosis rates have continued to rise consistently since that removal, which is the epidemiological result that definitively ends the causal argument. The original 1998 study that launched the thimerosal autism panic was retracted by The Lancet in 2010 after investigators documented data manipulation, ethical violations, and undisclosed financial conflicts of interest. The lead researcher lost his medical license. More than 30 independent studies conducted across multiple countries have examined thimerosal and autism outcomes. None found a causal relationship. Ethyl mercury and methyl mercury are as different biologically as ethyl alcohol in beer and methyl alcohol in industrial solvent. Getting them confused has consequences in both cases, and in this case, the confusion has been costing children their health for decades. 20. The instruction to take antibiotics on an empty stomach for fastest results follows an intuition that feels pharmacologically sound. Less food means faster transit, faster absorption, faster effect. You are sick, you want the drug working, and slowing it down with a meal seems counterproductive. Whether a specific antibiotic should be taken with or without food is determined by the chemistry of that individual drug, and the blanket empty stomach rule applies to some medications in some formulations and is actively wrong for others. Amoxicillin, one of the most widely prescribed antibiotics on the planet, can be taken with or without food. Food does not meaningfully alter its absorption profile. Azithromycin in tablet form should be taken with food to reduce gastrointestinal side effects, though specific formulations vary. Fluoroquinolones like ciprofloxacin should avoid specific foods, particularly dairy products and calcium-fortified juices, because calcium ions chelate the drug and reduce absorption by binding to it directly. The instruction there is not empty stomach universally, it is avoid specific chelating substances. Metronidazole causes significantly less nausea when taken with food, and its gastrointestinal side effect burden is substantial enough that food compliance meaningfully affects whether patients complete their course. The true empty stomach instruction applies specifically to certain penicillins where food significantly reduces peak plasma concentrations. But this is drug-specific, not a universal pharmacological rule that transfers across antibiotic classes. Patient adherence collapses when medications cause nausea. For some antibiotics, the empty stomach instruction produces enough discomfort that patients stop completing their courses, which creates far worse clinical outcomes than slightly reduced peak absorption from taking the drug with a meal. There is no universal rule. There is only the specific drug, the specific formulation, and the specific patient. and a generalized instruction written decades ago covers none of that nuance accurately. 21. If one dose helps, 2 doses will help twice as much. You are suffering, you want faster results. And the logic of proportionality, more input, more output, feels like common sense applied to medicine. Pharmacology operates on dose-response curves, and those curves are not linear. They are sigmoid, S-shaped, meaning below a threshold there is no effect, within the therapeutic range increasing dose increases effect, and above the therapeutic ceiling additional dose produces no further benefit while toxicity continues to rise. Most drugs hit that efficacy ceiling well before they hit their toxicity ceiling, and doubling a dose when you are already at the ceiling does not double the result, it just moves you up the toxicity curve. Acetaminophen is the clearest illustration of why this matters. Doubling the dose does not double pain relief because you are already at the therapeutic ceiling for analgesia. It does meaningfully increase the risk of liver injury, which occurs through a separate dose-dependent pathway that does not plateau at the same point. For many antibiotics, the minimum inhibitory concentration, the lowest drug concentration that prevents bacterial growth, is the clinical target. Exceeding it does not eliminate bacteria faster. It increases side effects without accelerating the bactericidal effect. Doubling antihypertensive medication without medical supervision can cause acute hypotension and syncope. Proton pump inhibitors show minimal additional acid suppression benefit beyond standard doses, while higher doses increase fracture risk, magnesium deficiency, and susceptibility to intestinal infection. Narrow therapeutic index drugs, lithium, digoxin, warfarin, are the category where this becomes acutely dangerous. The toxic dose for these medications is close enough to the effective dose that self-escalation based on impatience can produce toxicity without the patient realizing the line was crossed. More is not more in pharmacology. Above the efficacy ceiling, the only thing that scales reliably with dose is the damage. 22. Prescription amphetamines are widely believed to function as universal cognitive enhancers, a focus pill that works on any brain that takes it. Students without attention deficit hyperactivity disorder seek them specifically for this reason, framing the use as a performance tool and EDGE, a study aid. The belief that stimulants sharpen cognition across all users, regardless of neurological baseline, is built on misattribution, placebo effect, and a fundamental misunderstanding of how attention deficit hyperactivity disorder affects brain function. In people with ADHD, stimulant medications normalize activity in the prefrontal cortex, which is underactive relative to a neurotypical baseline. The paradoxical calming effect observed clinically is the result of bringing an underperforming regulatory system up to functional range. In neurotypical individuals, stimulants push an already normal dopamine system into overdrive. The subjective experience of heightened focus, energy, and confidence is real. But studies show that objective performance on complex cognitive tasks, as opposed to rote or repetitive work, may not improve and can actually degrade. A meta-analysis published in the journal Psychopharmacology found that stimulants in neurotypical subjects improved performance on simple, low-complexity tasks, but showed no consistent benefit on complex reasoning and working memory, the exact tasks most users are trying to enhance. The subjective experience of feeling sharper does not reliably correlate with objective performance improvement. This is a well-documented phenomenon researchers refer to as amphetamine overconfidence. Non-medical stimulant use carries cardiovascular risks, including elevated heart rate and blood pressure, psychiatric risks, including stimulant-induced psychosis, and genuine dependency risk, none of which are reduced by the absence of an ADHD diagnosis. Misuse of prescription stimulants is explicitly classified as prescription drug abuse, regardless of the academic or professional framing applied to it. A well-tuned engine does not improve by being flooded with excess fuel. It runs hot until something gives. 23. Cough syrup is one of the most purchased over-the-counter products in the world, bought by people doing what seems pharmacologically obvious, taking medicine that addresses the symptom they have. Multiple systematic reviews have examined whether the main active ingredients in most over-the-counter cough medicines actually suppress cough in real patients, and the results are not what the $3 billion annual sales figure would lead you to expect. A 2014 Cochrane review found insufficient evidence to support the use of over-the-counter cough preparations for acute cough in children, and the Food and Drug Administration subsequently issued safety warnings recommending against the use of most over-the-counter cough medicines in children under 2 years old, a restriction later extended to under 4 by many pediatric professional bodies. Dextromethorphan, the most common active antitussive ingredient in over-the-counter formulations, does show some centrally mediated cough suppression in laboratory models, but clinical trial evidence for real-world effectiveness in acute cough is inconsistent and modest at best. Guaifenesin, marketed as an expectorant that thins mucus and makes it easier to clear, has limited evidence of clinical benefit in acute respiratory infections. The mechanism of cough in viral respiratory illness is physiologically protective. It clears mucus and debris from airways. Pharmacologically suppressing it without addressing the underlying viral process may impede that clearance function. The over-the-counter cough syrup industry generates approximately $3 billion in annual United States sales, representing a product category whose clinical evidence base would not survive the scrutiny of a modern new drug application to the FDA. Multiple clinical trials of honey administered to children with nighttime cough from upper respiratory infections have consistently outperformed dextromethorphan and placebo. That is not a folk remedy footnote. That is a replicated clinical trial result. You are buying a $15 bottle of liquid that a Cochrane review could not meaningfully distinguish from sugar water. 24. Many patients with type 2 diabetes watch family members go on insulin and subsequently develop kidney failure, lose limbs, or lose their vision. And they draw the obvious conclusion: the insulin caused those outcomes. This belief stops patients from accepting appropriate treatment for years, sometimes for the entirety of the period during which intervention could have prevented exactly the complications they are trying to avoid. Those complications were caused by years of uncontrolled blood glucose before insulin was ever started. Insulin is the tool that prevents them. Diabetic nephropathy, retinopathy, and peripheral neuropathy are all caused by chronic exposure to elevated blood glucose through mechanisms involving advanced glycation end products, oxidative stress, and microvascular damage. Processes that accumulate during the years of inadequately controlled diabetes that precede insulin initiation. In clinical practice, type 2 diabetes is typically managed with oral medications first, and insulin is added later when beta cell function has declined substantially. Patients who reach insulin have usually had poorly controlled glucose for years, which is why complications frequently emerge around the same time insulin is started, not because of the insulin, but because of the timeline of the disease. The United Kingdom Prospective Diabetes Study, one of the longest and largest diabetes trials ever conducted, demonstrated that intensive blood glucose control, including insulin when necessary, significantly reduced microvascular complications. Fear of insulin is documented to result in delays of up to 7 years in appropriate initiation among many type 2 patients. During those 7 years, irreversible complications develop. Psychological insulin resistance is now a recognized clinical phenomenon with its own research literature, representing a significant barrier to diabetes management across every population studied. Blaming insulin for diabetic complications is a precise reversal of the pharmacological reality. The fire was already running for years. The delay in calling for help was the problem, not the response. 25. The fear is stated plainly by many women considering hormonal contraception. Years on the pill will permanently alter your fertility, and when you eventually want children, your reproductive system will be unable to return to its natural function. This belief stops people from starting contraception and is not supported by the clinical evidence that has accumulated across decades of study. Fertility returns after stopping oral contraceptives, typically quickly. The pill temporarily suppresses ovulation, a process that reverses completely upon discontinuation. Multiple large-scale studies have confirmed that former pill users have equivalent fertility to women who never used oral contraceptives. The average time to ovulation after stopping combined oral contraceptives is 1 to 3 months, with some women ovulating within weeks of stopping. A small proportion experience a delay of up to 6 months, which resolves without intervention. Post-pill amenorrhea, the absence of menstrual periods for more than 3 to 6 months after stopping, warrants clinical investigation, but not because the pill caused infertility. It warrants investigation because the pill was masking an underlying hormonal condition such as polycystic ovary syndrome or hypothalamic dysfunction that existed before contraceptive use began. Infertility in women who used oral contraceptives is statistically accounted for by age. Women who use contraception for years are older when they attempt conception, and by pre-existing conditions that were present before they ever started the pill. The pill can also protect fertility in certain conditions. It reduces the risk of endometriosis progression and ovarian cyst development, both of which can impair fertility if left untreated. Despite robust scientific consensus on this point, surveys consistently find that large percentages of young women and their parents believe the pill causes infertility, a myth that directly and measurably contributes to unintended pregnancy rates. The pill pauses a process. Pausing does not erase it, and your reproductive system is not a mechanism that degrades faster for being temporarily at rest. 26. You start the prescription and you expect results. Within days at the outside, because that is how medication works in your experience. You take a painkiller and the pain responds. You take an antibiotic and the infection clears. Antidepressants operate on a timeline determined by neurobiology, not by patient preference, and misunderstanding that timeline is one of the most common reasons people abandon treatment that would have worked if they had continued. Selective serotonin reuptake inhibitors increase synaptic serotonin within hours of the first dose. The clinical antidepressant effect takes 2 to 6 weeks to emerge. That gap itself is evidence that serotonin reuptake inhibition is not the complete mechanism of therapeutic action. If it were, the effect would appear when the drug concentration does. The 2 to 6 week lag is now understood to involve neuroplastic changes, including upregulation of brain-derived neurotrophic factor and processes of hippocampal neurogenesis that require weeks to develop. The period between starting medication and achieving therapeutic effect is clinically sensitive for severely depressed patients. Antidepressants may begin improving energy and motivation before improving mood, which can transiently increase risk in the early weeks. The precise reason clinical guidelines recommend close follow-up within the first 2 to 4 weeks of initiation, and why FDA black box warnings on antidepressants address this early treatment window specifically. Many patients stop during weeks 2 to 4 because the medication is not working, often while also experiencing initial side effects that appear before any benefits. Non-response versus inadequate trial duration is one of the most common explanations behind treatment-resistant depression diagnoses. Patients who abandon medication before the therapeutic window is reached are frequently labeled treatment-resistant when they simply did not continue long enough for the biological process to complete. Antidepressants are not a switch. The biology requires time, and abandoning the process at week 3 is functionally equivalent to deciding the seed did not grow before checking whether the ground was ready. 27. The finality of it. You'll be on this for the rest of your life, is enough to make many patients resist starting antihypertensive medication entirely or stop at the moment they feel better, convinced they have escaped a pharmaceutical commitment they never agreed to. Blood pressure medication is not inherently permanent. It manages a physiological condition within a biological system that remains responsive to the inputs you provide it. For some patients, meaningful lifestyle changes can reduce or eliminate the need for medication entirely. Clinical guidelines from both the American College of Cardiology and the European Society of Hypertension explicitly acknowledge that patients who achieve substantial weight loss consistently follow dietary approaches that reduce sodium and emphasize vegetables and lean protein, exercise regularly, and moderate alcohol consumption can achieve blood pressure reductions equivalent to what a single antihypertensive drug produces. Weight loss of approximately 1 kilogram is associated with a reduction of approximately 1 millimeter of mercury in systolic blood pressure. Clinically meaningful weight loss of 10 to 15 kilograms can produce the equivalent of an antihypertensive medication. Step-down therapy, gradual reduction of medication as lifestyle improvements take effect, is a recognized clinical approach used in younger hypertensive patients who make substantive lifestyle modifications and maintain them. The myth of permanence is self-fulfilling in a specific way. Patients told they will be on it forever tend to make fewer lifestyle changes because the medication feels like it is already handling the problem. The fear of permanence causes a different group, high-risk patients, to avoid medication entirely, sustaining years of elevated blood pressure while pursuing lifestyle changes that are insufficient for their baseline risk level. Hypertension produces no symptoms until a catastrophic cardiovascular event occurs. That is the clinical reality that makes the resistance to treatment so costly. The exit ramp exists, but it requires real work to build, and most people opt for the comfortable assumption that no exit is available rather than constructing one. 28. Side effects feel like your body sending a clear signal. This drug is wrong, this is a rejection, the chemistry does not fit. The intuitive response is to stop, and stopping feels like listening to your own physiology rather than overriding it. Most medication side effects are temporary. They occur during the biological adjustment period and resolve within days to weeks in the majority of patients. Abruptly, stopping many medications carries risks that substantially exceed the side effects prompting the decision to quit. Selective serotonin reuptake inhibitors and serotonin norepinephrine. Reuptake inhibitors commonly cause nausea, jitteriness, and sleep disruption in the first 1 to 2 weeks of use. These symptoms resolve in the vast majority of patients without dose adjustment or discontinuation, yet they are a leading cause of early treatment abandonment in a condition, depression, where treatment abandonment directly worsens outcomes. Statins are among the most abandoned medication classes due to muscle aches, yet controlled rechallenge trials show that in many patients, the muscle symptoms are not pharmacologically attributable to the statin, pointing instead to a nocebo effect, the pharmacological opposite of placebo, in which the expectation of side effects causes their experience. Abruptly stopping beta blockers used for cardiovascular conditions causes rebound sympathetic activation. Elevated heart rate, rising blood pressure, and in patients with underlying coronary artery disease, a meaningful risk of acute myocardial infarction triggered by the withdrawal. Corticosteroids taken for more than a few weeks suppress adrenal function, and abrupt discontinuation can cause adrenal insufficiency, a hormonal emergency that is potentially life-threatening. Many side effects are dose-dependent and respond to dose reduction rather than discontinuation, an option patients forfeit entirely when they stop without consulting the prescriber. The clinical protocol for essentially every medication class includes guidance on managing initial side effects, and that guidance almost never opens with immediately discontinue. Stopping at the first sign of discomfort is abandoning the adjustment phase before the adjustment completes. 29. The FDA approval process implies that the drug has been tested rigorously in a representative sample of human beings, and that the dosing, safety, and efficacy data in the prescribing information reflects people across the full spectrum of ages, weights, biological sexes, and health conditions. The clinical trial populations that generate that data are notoriously, documentably unrepresentative. And a prescription written for you is frequently an extrapolation from data gathered on people who are not like you in ways that matter pharmacologically. Women were systematically excluded from most clinical trials until the National Institutes of Health Revitalization Act of 1993 mandated their inclusion. Decades of dosing guidelines were established on male-only data and then applied universally to all patients. The Food and Drug Administration's own 2020 analysis of drug labeling found that women represent only 41% of clinical trial participants despite comprising 50% of the population, and reporting of sex-specific outcomes remains inadequate across the literature. Drug metabolism differs meaningfully by biological sex. Women generally have higher body fat percentages affecting fat-soluble drug distribution, lower average body weight, and different hormonal environments affecting liver enzyme activity, all producing different pharmacokinetic profiles. The zolpidem dose disparity is the most cited documented example. Women were found to metabolize the drug significantly more slowly than men, resulting in morning blood concentrations sufficient to impair driving. The FDA required a 50% dose reduction for women. This correction arrived more than 2 decades after a single-dose recommendation had been applied to all adults. Elderly patients are frequently excluded from clinical trials and then constitute a large proportion of the medicated population. Polypharmacy management in older patients is therefore largely extrapolated rather than directly evidenced. Pediatric dosing is derived from adult data using weight-based calculations that fail to account for the dramatically different pharmacokinetics of developing organ systems. The drug was largely tested on healthy men in their 30s. You may not be a healthy man in your 30s, and the prescription crossed that gap with arithmetic and an assumption. 30, the terms are used interchangeably on medication labels, in patient conversations, and across popular media, creating a confusion that drives some patients to refuse medications they genuinely need out of misplaced addiction fear, and simultaneously allows other patients to develop genuine addiction without recognizing it because they were never told what the word actually means. Physical dependence and addiction are clinically distinct conditions with fundamentally different mechanisms and implications. Physical dependence refers to the body's adaptation to a substance such that abrupt discontinuation produces a withdrawal syndrome. It can occur with medications that carry no abuse potential and no psychological craving whatsoever. Corticosteroids, beta blockers, and antidepressants all produce physical dependence with regular use, none of which are considered addictive in the clinical sense. Addiction is defined by compulsive use despite negative consequences, loss of control over use, craving, and continued use despite clear harm. It is a psychological and neurological syndrome, not simply a physical adaptation. Many patients who are physically dependent on a medication like a selective serotonin, reuptake inhibitor, or a cardiovascular drug are not addicted to it. They experience discontinuation symptoms when they stop abruptly, but they do not crave the medication, escalate doses for psychoactive effect, or take it compulsively. Conversely, people can develop addiction to substances without classical physical dependence. Stimulant addiction does not consistently produce a physical withdrawal syndrome in the traditional sense, but it involves intense psychological craving and compulsive use that meets every diagnostic criterion for addiction. The habit-forming label on over-the-counter antihistamines or mild sleep aids was historically applied loosely to describe behavioral patterns and tolerance, not the clinical addiction framework, but patients interpret the language identically regardless of what was meant. This confusion produces two distinct and opposite clinical harms simultaneously, and resolving it requires understanding that physical dependence is the body adapting to a chemical environment, while addiction is the identity reorganizing around it. 31. Chemotherapy destroys your immune system is stated with the confidence of received fact, and it shapes some of the most consequential decisions patients make, including refusing treatment that could have been effective. The narrative of total immune annihilation is a significant oversimplification of a variable, temporary, and clinically managed physiological process. Chemotherapy-induced immunosuppression is real, it is clinically significant, and it is neither total nor permanent, and the degree to which it occurs varies considerably depending on the specific drug regimen being used. The primary mechanism is myelosuppression, suppression of bone marrow activity, which produces immune cells. Chemotherapy targets rapidly dividing cells, and immune cell precursors in the bone marrow divide rapidly. The degree and duration of immunosuppression varies enormously by regimen. Some protocols produce minimal immune impact, while others, particularly those used in hematological cancers or bone marrow transplant conditioning, produce profound and prolonged suppression that requires intensive supportive care. Immunosuppression during chemotherapy is monitored through regular complete blood counts. The nadir, the lowest point of immune cell counts, typically occurs 7 to 14 days after each treatment cycle, with recovery underway by the time the next cycle begins for many standard regimens. Modern oncology includes specific strategies to mitigate immune suppression: granulocyte colony stimulating factor injections to stimulate neutrophil recovery, prophylactic antibiotics, and antifungal medications during the vulnerable window. The immune system reconstitutes fully in most patients after chemotherapy completion, with reconstitution time varying by regimen and individual patient factors. Many patients who refuse chemotherapy based on immune destruction fears instead die of cancers that were treatable. The risk of infection during chemotherapy is real and is actively managed throughout treatment. The risk of untreated cancer is not managed. It progresses. Chemotherapy does not erase your immune system. It suppresses it in a controlled and monitored window while doing the primary work it was prescribed to accomplish. 32. The regulatory arbitrage belief, if it's legal in another country, it cannot be that dangerous, is used to justify purchasing medications from foreign online pharmacies, using unapproved treatments, and dismissing domestic regulatory caution as excessive bureaucracy rather than evidence-based risk assessment. Drug approval in any country represents a risk-benefit calculation made at a specific point in time based on the evidence available at that moment for the population in question. It is not a permanent universal safety guarantee, and it is not transferable. Thalidomide is the historical benchmark. It was approved and widely used in Europe and the United Kingdom as a sedative and anti-nausea medication for pregnant women in the late 1950s and early 1960s, causing approximately 10,000 cases of severe limb deformities in newborns. The Food and Drug Administration rejected it largely because one reviewer, Frances Oldham Kelsey, demanded additional neurological safety data that the manufacturer could not provide. Regulatory standards differ meaningfully between jurisdictions. The FDA and the European Medicines Agency have different approval thresholds, post-market surveillance requirements, and risk management protocols. A drug approved in one jurisdiction may not meet the safety evidence standard of another, not because one agency is wrong, but because the standards are genuinely different. Vioxx was approved by both the FDA and EMA and regulatory agencies across the developed world. It was subsequently linked to tens of thousands of cardiovascular deaths and withdrawn globally in 2004. Approval in every country simultaneously did not prevent that outcome. Online pharmacies selling foreign approved medications frequently sell counterfeit, underdosed, or contaminated products. A 2020 World Health Organization report estimated that 1 in 10 medicines in lower income countries are substandard or falsified. Approval elsewhere is another country's risk-benefit assessment for their population at that time with that evidence. It does not travel with the pill across the border. 33. The fear of personality change is one of the most significant and most documented barriers to psychiatric treatment, initiation, and maintenance. The specific concern is stated in multiple ways. I don't want to become a zombie, I won't feel like myself, medication will flatten everything out. But the core belief is that psychiatric drugs alter who you fundamentally are. For most patients on appropriately chosen and appropriately dosed medication, this is a reversal of what actually happens. The illness was altering who they were. The medication is an attempt to reduce that alteration. Emotional blunting is a real and documented side effect of selective serotonin reuptake inhibitors in a subset of patients characterized by reduced emotional range, decreased motivation, and a subjective sense of flatness. It is a recognized side effect, not the intended therapeutic effect, and it frequently responds to dose adjustment or a switch to a different medication within the same or a different class. Many patients report feeling more authentically like themselves on psychiatric medication, because the state they were treating, characterized by depression, severe anxiety, or psychosis, was what had been reshaping their personality and behavior over months or years of illness. Antipsychotics used at excessive doses produce blunting, cognitive slowing, and sedation. The historical criticism of institutional psychiatric care involved genuine over-medicating that is distinct from modern evidence-based prescribing at appropriate doses. A study published in the Journal of Affective Disorders in 2017 found that personality trait changes attributed to selective serotonin reuptake inhibitors, specifically reductions in neuroticism, were primarily the result of symptom improvement rather than a direct drug effect on personality structure itself. Refusing medication due to fear of personality change while living with untreated severe mental illness does alter personality through the illness itself, often dramatically and over years. The medication is not changing who you are. The untreated condition has been doing that for a long time already. 34. Supplement marketing has mastered the art of borrowing pharmaceutical language, clinically studied, doctor-recommended, comparable results, and applying it to products that exist in a regulatory environment with none of the evidentiary requirements those phrases imply when applied to actual drugs. When head-to-head clinical trials have been conducted between supplements and the pharmaceutical interventions they are positioned as replacing, the results are substantially less impressive than the labels suggest. St. John's wort against selective serotonin, reuptake inhibitors for depression. Cochrane reviews indicate modest efficacy for mild to moderate depression, comparable to low-dose SSRIs in some analyses, but not for severe depression, and the interaction profile creates a separate clinical risk that prescription antidepressants do not carry in the same way. Glucosamine and chondroitin for osteoarthritis. The glucosamine and chondroitin arthritis intervention trial, funded by the National Institutes of Health, found no significant benefit over placebo for most participants, despite a widespread clinical use and a multi-billion-dollar market. A possible benefit in the subgroup with moderate to severe pain has not been consistently replicated. Prescription omega-3 at 4 grams daily as eicosapentaenoic acid demonstrated significant cardiovascular risk reduction in the REDUCE-IT trial. Standard over-the-counter fish oil supplements at typical doses do not. Supplement dosing is unregulated in the United States, meaning 2 bottles of the same product from different manufacturers may contain widely varying concentrations of the active ingredient. A 2015 investigation of herbal supplements by the New York Attorney General found that many products lack the labeled ingredient entirely. Melatonin supplements are sold in doses ranging from half a milligram to 10 milligrams, while research suggests half to 1 milligram is the physiologically active range. Many commercial products contain 5 to 20 times the effective dose. The placebo response in supplement trials is robust, meaning subjective improvement is real even when objective clinical outcomes do not differ from placebo. The supplement is the cover band. Sometimes they deliver. But the quality control of the original act is not present, and occasionally you show up to a venue with nothing on stage. 35. Topical medications are dismissed with a phrase that does enormous clinical damage. It's just a cream. The logic is intuitive. You are not swallowing anything, nothing is entering your bloodstream, the effect stays where you put it. The skin is not an impermeable wall. It is an absorption organ, and topical medications in pharmacologically active drug classes can produce measurable systemic exposure and genuine systemic effects that have nothing to do with where you applied the product. Topical corticosteroids are the most widely prescribed topical medication class globally, and with prolonged use, particularly on large body surface areas, under occlusion, or in skin folds, they are absorbed sufficiently to suppress hypothalamic pituitary adrenal axis function. That is a systemic endocrine effect produced by a cream. Topical testosterone gels used in men with low testosterone transfer to skin contact partners through casual physical contact, causing premature puberty in young boys and virilization in women. The Food and Drug Administration issued specific black box warnings about this secondary exposure risk. Transdermal drug delivery is not a workaround used because it barely works. It is a pharmacological design choice that deliberately produces systemic effects while bypassing first-pass liver metabolism. Nitroglycerin patches, fentanyl patches, nicotine patches, estrogen patches, and scopolamine patches all deliver systemically by design. Topical non-steroidal anti-inflammatory drugs like diclofenac gel are absorbed into the bloodstream and carry the same cardiovascular and renal risks as oral versions at lower but clinically relevant concentrations. The assumption of purely local effect has caused patients and some clinicians to use topical steroids more liberally than they would ever use equivalent oral steroids, with documented consequences including adrenal crisis in reported cases. Fentanyl patch misapplication has caused overdose deaths. The route of administration does not erase the pharmacology. The skin is a membrane, not a wall, and it's been quietly doing its job the entire time you assumed otherwise. 36. The interaction warnings printed in package inserts are widely treated as legal padding, boilerplate protection added by manufacturers to cover unlikely scenarios so the company cannot be sued when something unusual happens. In practice, clinically significant drug interactions are far more common than patients assume, are frequently missed in the clinical settings where they should be caught, and are directly implicated in thousands of preventable hospitalizations and deaths annually. A systematic review published in the British Journal of Clinical Pharmacology estimated that adverse drug interactions account for approximately 6.5% of all hospital admissions, and that the majority of those interactions were predictable and preventable with adequate medication review. Warfarin is involved in more clinically significant interactions than almost any other medication in current use. It interacts with antibiotics through effects on gut bacteria and liver enzymes, with non-steroidal anti-inflammatory drugs through bleeding risk amplification, with antifungal medications through enzyme inhibition, and with dozens of herbal supplements, making it one of the leading causes of medication-related hospitalization. QT prolonging drugs represent a separate and serious category. Certain antiarrhythmics, some antibiotics, including azithromycin and fluoroquinolones, antipsychotics, and some antihistamines, can each prolong the cardiac QT interval individually, and in combination, their effects are multiplicative rather than simply additive, potentially triggering a fatal ventricular arrhythmia. Serotonin syndrome, a potentially life-threatening excess of serotonergic activity, can result from combining multiple serotonergic drugs. Selective serotonin reuptake inhibitors with triptans, with tramadol, with the antibiotic linezolid, or with St. John's wort. Grapefruit juice contains compounds that inhibit a gut wall enzyme responsible for metabolizing numerous drugs, dramatically increasing the bioavailability of statins, certain calcium channel blockers, and immunosuppressants. A food interaction printed clearly on labels that most patients never read. The warnings are not padding. They are a map of a chemical landscape your pharmacist is navigating. You are the one driving through it. 37, the bargain made in the post-surgical suite, the emergency room, or the pain clinic sounds reasonable on both sides. Take these for a few weeks, get through the acute period, and stop. You are informed, you are not the type, and it is a short course. The neurobiological window for opioid-induced reward pathway changes is shorter than most patients, and historically, most prescribers, believed, and the psychological conditions of acute pain create an environment that is distinctly favorable for rapid and unintended attachment. Research published in BMJ Open, analyzing millions of opioid prescriptions, found that the probability of long-term opioid use increases sharply after the 5th day of prescription use and increases again after the 31st day. The trajectory from acute management to chronic use often establishes itself within the first month of treatment, well inside the window that patients consider safely short-term. Acute pain produces anxiety, fear, and vulnerability, psychological states that amplify the rewarding properties of opioid analgesia beyond simple pain relief. The drug simultaneously eliminates pain and reduces the emotional distress accompanying it, which establishes a powerful and specific association that has nothing to do with willpower. The efficacy of opioids for acute pain frequently creates a subjective impression that the drug is uniquely effective, nothing else has ever worked this well, which sets a comparison point that shapes every future pain management expectation. Prescription duration at initial acute pain prescriptions predicts long-term use. Patients given 3-day supplies showed significantly lower rates of persistent use than those given 7-day supplies for the same clinical indication. Pain catastrophizing, the tendency to ruminate on pain and expect the worst possible outcomes, is a strong psychological predictor of progression from acute to chronic opioid use that cannot be assessed from the outside of the prescription bottle. The control you are confident about at day 3 was never the relevant measurement. The relevant data point is week 6, when the neurochemistry has already been running a different conversation without you. 38. The preemptive logic sounds medically responsible. A bacterial secondary infection might develop after this viral illness, so taking antibiotics early prevents it from establishing itself before it becomes serious, proactive, sensible. The clinical evidence does not support this reasoning for healthy, non-immunocompromised patients, and the practice actively causes harm through mechanisms that are well characterized and predictable. Cochrane reviews of prophylactic antibiotic use in uncomplicated upper respiratory viral infections in immunocompetent adults consistently show no reduction in complication rates and no reduction in illness duration, alongside documented side effects from the antibiotics themselves that occur in patients gaining no therapeutic benefit. Your gut contains approximately 38 trillion bacteria, and that community plays a central and active role in immune function. A course of broad-spectrum antibiotics significantly disrupts its composition for weeks to months and may paradoxically reduce resistance to secondary infection by eliminating the protective commensal bacteria that were occupying the ecological space. Clostridioides difficile colitis, a potentially fatal intestinal infection, is almost exclusively associated with antibiotic exposure, which eliminates the gut bacteria that normally suppress C. Difficile populations. More than 450,000 cases occur in the United States annually, with approximately 20,000 deaths. A direct consequence of antibiotic use, including unnecessary antibiotic use, driven by exactly the preventive logic described above. Secondary bacterial pneumonia after influenza is a recognized complication, and the evidence-based management is prompt antibiotic treatment if and when secondary infection is confirmed, not blanket prophylactic antibiotic therapy for everyone with a viral illness. Antibiotic-prescribed patients with viral illness face all the side effects of the drugs: gastrointestinal disruption, allergic reaction risk, C. Difficile exposure, with none of the antibacterial benefit because the target organism is not present. Taking antibiotics to prevent a bacterial complication from a virus is pharmacologically equivalent to spraying pesticide inside your house to prevent a bear from entering. The target species is completely unaffected. Everything else in the environment takes the damage. 39. The cultural script around psychiatric medication is deeply encoded and remarkably consistent. Try talking, try lifestyle changes, try harder, try anything else first, and only after everything has failed do you accept that medication is necessary, because needing it means the problem was serious enough to require something real. For a number of psychiatric conditions, medication is not the last resort. It is evidence-based first-line therapy, and delaying it causes measurable neurological harm that makes subsequent treatment more difficult. For moderate to severe major depressive disorder, clinical guidelines from the National Institute for Health and Care Excellence, the American Psychiatric Association, and the World Health Organization all recommend medication, alone or in combination with psychotherapy, as a primary first-line treatment, not as the option you arrive at after everything else has been tried and failed. Psychosis, including first episode schizophrenia, is a neurological emergency in which duration of untreated psychosis directly predicts long-term outcomes. Longer untreated duration is associated with greater functional decline, reduced treatment response, and poorer quality of life across follow-up periods measured in years. Antipsychotic medication should be initiated promptly, not held in reserve, while other approaches are attempted. Bipolar disorder with acute mania carries serious safety risks, including severely impaired judgment and psychosis. Mood stabilizers and antipsychotics are first-line interventions, not late additions. After lifestyle strategies have been given their chance, neuroimaging evidence increasingly supports the neurotoxicity of untreated psychiatric illness. Prolonged cortisol exposure in severe depression is associated with hippocampal volume reduction, and untreated psychosis is associated with progressive gray matter changes. The stigma sustaining the last resort framing is measurably highest in the communities where mental illness itself carries the greatest stigma, creating a feedback loop in which the people most in need of timely treatment are the last to receive it. Treating medication as a last resort for a clinical illness is a position that would be considered indefensible in almost every other branch of medicine. 40. Proton pump inhibitors, omeprazole, lansoprazole, pantoprazole, are among the most widely prescribed and most commonly self-purchased medications in the world. Millions use them chronically without a second thought because the short-term trials that established their original safety profile showed a clean result, and that result became the assumption under which long-term use expanded well beyond the clinical context for which the drugs were designed. Post-market surveillance has documented a range of serious adverse effects associated with long-term proton pump inhibitor use that were not apparent in those short-term trials, and many patients using these drugs daily have never been told these associations exist. Chronic proton pump inhibitor use is associated with hypomagnesemia, abnormally low magnesium levels, because magnesium absorption in the gut requires an acidic environment. Prolonged acid suppression impairs that process and can cause cardiac arrhythmias, seizures, and neuromuscular symptoms when magnesium levels fall sufficiently. Long-term acid suppression also reduces absorption of vitamin B12, which requires stomach acid to be released from its food-bound form, and reduces calcium absorption in a way that contributes to increased fracture risk. A large study published in the British Medical Journal found an association between long-term proton pump inhibitor use and increased risk of Clostridioides difficile infection. Stomach acid provides a significant antimicrobial barrier, and suppressing it reduces the body's resistance to ingested pathogens. Several large observational studies have identified associations between chronic use and increased risk of chronic kidney disease, with the biological mechanisms under active investigation. Proton pump inhibitors are intended for short-term use, 4 to 12 weeks, for most clinical indications. Many patients have been on them for years or decades without reassessment of whether the original indication still applies. Your stomach acid exists for biological reasons beyond creating discomfort. Disabling it permanently without regular reassessment is removing a system and hoping nothing in the body's architecture depended on it. 41. You feel the medication less than you used to. The obvious interpretation presents itself immediately. The drug has stopped working, your body has adapted past it, and it is time to escalate the dose, switch medications, or accept that treatment has failed. Tolerance is a spectrum of pharmacological phenomena that mean different things in different drug classes, and interpreting all of them as treatment failure is a misreading of the biology that leads to clinical decisions with poor outcomes. Tolerance to side effects almost universally develops before tolerance to therapeutic effects. Nausea from antidepressants, sedation from antihistamines, and gastrointestinal irritation from metformin diminish over days to weeks while the clinical benefit persists. Patients who stop at the side effect stage never reach the therapeutic stage. Opioid tolerance, the need for increasing doses to achieve equivalent pain relief, is a genuine and well-characterized clinical phenomenon in chronic pain management, but pain specialists distinguish carefully between tolerance-driven dose escalation and disease-driven dose escalation, where the underlying condition is worsening and pain is increasing independent of the drug. Nitrate tolerance is a specific and mechanistically understood phenomenon in which continuous nitroglycerin use causes desensitization of the vascular response, managed through scheduled nitrate-free intervals, typically overnight, not through drug abandonment. Benzodiazepine tolerance develops rapidly, within days to weeks of regular use, which is a primary clinical reason guidelines recommend short-term use. Patients who find sleep medication wearing off often interpret this as a signal to increase the dose when it is actually a signal that the window for appropriate use has already passed. For antihypertensives and statins, drugs that work on measurable physiological parameters rather than subjective symptoms. Patient perceived tolerance is essentially irrelevant. The drug's efficacy is read in your blood pressure numbers and your LDL panel, not in how you feel on a given morning. Sorting out what tolerance means in your specific drug class requires a pharmacologist's framework, not a personal assessment made at the bathroom mirror. 42. The drug test came back negative. The interpretation is immediate. The drug is gone, the system is clear, the problem is resolved. A negative drug test reflects a specific test's ability to detect specific compounds above a specific threshold concentration in a specific biological sample at a specific time. It is a detection limit result. It is not a full-body chemical inventory. Standard urine immunoassay drug screens test for drug metabolites above a threshold concentration. Below that threshold, the test reports negative, even if residual drug remains present. This is a detection limit, not an absence. THC metabolites can be detectable in urine for 3 to 30 days after last use, depending on frequency of use and body fat percentage. A first-time cannabis consumer may test negative within 72 hours, while a chronic daily user may test positive for 4 to 6 weeks after complete cessation, because THC is fat-soluble and releases slowly from stored tissue. Benzodiazepine detection presents a specific complexity. Certain benzodiazepines, including lorazepam and alprazolam, may produce negative results on standard screens calibrated for diazepam and its metabolites. A negative benzodiazepine panel does not rule out benzodiazepine exposure. Opioid panel variability is significant. Synthetic opioids, including fentanyl, oxycodone, and tramadol, frequently require specific confirmatory tests to detect. A standard opioid screen calibrated for morphine metabolites can return negative in a patient actively using fentanyl. Blood concentrations of drugs do not follow the same detection timeline as urine. A drug may be undetectable in urine while still present at pharmacologically active concentrations in the central nervous system, particularly with fat-soluble compounds that redistribute from plasma into tissue. A patient cleared for driving or a safety-sensitive role based on a negative drug screen may still have drug concentrations affecting reaction time, judgment, and cognition. A negative test means the test did not find it above the line it was calibrated to see. It is not a receipt confirming the system is empty. 43. Pill splitting is presented as a financially intelligent workaround. Tablets often cost the same price regardless of dose, so purchasing the higher dose tablet and splitting it doubles your supply at the same cost. For certain medications in specific formulations, this is safe and even recommended by prescribers as a legitimate cost management strategy. For a significant category of medications, splitting destroys the pharmacological mechanism and can produce acute toxicity. Extended release, sustained release, controlled release, and enteric-coated formulations should never be split. These products rely on a matrix structure or a specialized coating that controls the rate at which the drug is released into the body. Splitting destroys that structure and delivers the full intended dose rapidly, a phenomenon called dose dumping, rather than gradually over the intended release period. Extended release opioid formulations carry specific black box warnings against splitting, crushing, or chewing for exactly this reason. The dose dumping of an extended release opioid produces a rapid, high concentration exposure that carries a acute toxicity risk. Many tablets have irregular shapes, unequal density distributions, or coatings that mean a visually equal split does not represent a pharmacologically equal half. Dose variability of 15 to 20% between the two halves of a home split tablet is not unusual, which matters considerably for narrow therapeutic index medications. For appropriate candidates, score tablets of simple immediate release medications, like certain blood pressure drugs or some antidepressants. Splitting is clinically reasonable and frequently physician recommended as a documented cost-saving approach. The Food and Drug Administration provides guidance, identifying medications that can be safely split and specifically labels formulations that should not be. Capsules should essentially never be opened and their contents divided unless the manufacturer specifically designates a sprinkle formulation. The encapsulation serves a pharmacological function in almost all other cases. Splitting a plain scored tablet is a reasonable strategy. Splitting a time-release formulation is a delivery system failure with consequences that begin the moment you swallow. 44. You get the flu shot and within days you are sick. The vaccine gave you the flu. The conclusion is drawn quickly and repeated confidently to anyone who asks why you do not bother with the shot anymore. The illness experienced after vaccination is either a normal immune response, coincidental infection from a pre-existing exposure, or in the case of live vaccines in specific populations, a mild and distinct reaction, not the disease itself in the form that causes serious harm. Inactivated vaccines, the flu shot, most COVID-19 vaccines, hepatitis vaccines, and inactivated polio vaccine contain killed pathogens or fragments of pathogens. They are incapable of causing infection because the pathogen cannot replicate. Feeling unwell afterward is the immune system mounting a response, not getting sick from the disease. Live attenuated vaccines, including measles, mumps, rubella, varicella, yellow fever, and oral typhoid, contain weakened live pathogens that can replicate but cannot cause full disease in immunocompetent individuals. In severely immunocompromised patients, attenuated strains can occasionally cause mild vaccine strain reactions, which is why these vaccines are specifically contraindicated in that population. Post-vaccination malaise, injection site soreness, fatigue, and low-grade fever result from cytokine release during immune activation. This is the immune system responding to a training stimulus. The response uses some of the same biological machinery as illness because it is mounted by the same system, but it is not infection. The incubation period for influenza is 1 to 4 days. Many people receive the flu shot during or just before this window, develop illness from a pre-existing exposure, and attribute it to the vaccine. Influenza vaccines are effective in 40 to 70% of recipients depending on strain match. Vaccinated people can still contract influenza if exposed to a strain not covered by that year's formulation, which patients reliably interpret as the vaccine having caused the illness. The COVID-19 mRNA vaccines contain no virus, only a lipid nanoparticle carrying an mRNA sequence. Replication of the pathogen is physically impossible. Your immune system met a training stimulus and responded. That is not an attack. That is the point. 45. The FDA approved this drug for one specific condition, and if your doctor is prescribing it for something else, something feels off. Like the drug is being repurposed without authorization, or you are being used as an experiment, or the prescriber is guessing rather than following established medicine. Off-label prescribing is legal, extremely common, and for many clinical conditions, constitutes the established evidence-based standard of care. The FDA approves drugs for specific indications based on the clinical trial data submitted by the manufacturer, and manufacturers pursue trials for indications that have commercial value, not necessarily for every clinical application the molecule may have. Approximately 1 in 5 outpatient prescriptions in the United States are written off-label. In oncology, psychiatry, and pediatrics, the rate is substantially higher. Amitriptyline was approved as an antidepressant in the 1960s. It is now prescribed far more commonly for chronic pain, migraine prevention, and sleep disorders. All off-label applications supported by substantial accumulated clinical evidence. Aspirin was approved for pain and fever. Its use in cardiovascular prevention, arguably its most clinically important modern application, is off-label. Minoxidil was approved as an antihypertensive oral medication. Hair loss treatment, in both topical and oral form, became its dominant commercial application as an off-label use. Pediatric off-label prescribing is nearly universal because pharmaceutical companies rarely fund pediatric clinical trials. Children represent a smaller commercial market, meaning most pediatric dosing is derived from adult data with weight-based calculations. This is considered standard clinical practice in pediatric medicine, not experimental prescribing. The FDA approval process answers a specific question: did the manufacturer fund and submit trials for this indication? It does not answer the question of whether the drug works for anything outside that submission. Those are completely different questions. The approval stamp tells you the company paid to study a particular use. It tells you nothing about the boundaries of the drug's actual pharmacology. 46, you read the package insert. The list of adverse effects runs for pages: seizures, liver failure, severe skin reactions, blood disorders, suicidal thoughts. Each listed effect sits on the page with equal visual weight, producing a combined impression that taking this medication means navigating a field of nearly equal and individually terrible risks. Package inserts are legal documents, not clinical probability guides. They include every adverse event that occurred in clinical trials above a reporting threshold, regardless of whether the drug caused it, and they provide no usable risk stratification for the patient reading them. Food and Drug Administration regulations require that adverse events occurring above a certain frequency in clinical trials appear in the adverse effects section, regardless of whether causation was established. A patient in a trial who took the drug and then experienced an unrelated event still contributes to this list. The European Medicines Agency uses a frequency classification system that provides actual numerical context. Very common means 1 in 10 or more patients, common means 1 in 100 or more, uncommon means 1 in 1,000 or more, rare means 1 in 10,000 or more, and very rare means fewer than 1 in 10,000. That structure gives patients a probability framework. Most United States package inserts do not provide this granularity, leaving patients with a list and no way to weigh it. The nocebo effect, the pharmacological opposite of placebo in which the expectation of side effects causes patients to experience them, is well documented in clinical research. Informing patients about potential side effects in ways that increase anxiety measurably increases their subjective experience of those effects. The statin myopathy example is instructive. Rhabdomyolysis, the clinically significant muscle damage associated with statins, occurs in approximately 1 to 5 patients per 100,000 patient years. It is listed prominently. The cardiac events statins prevent occur at rates orders of magnitude higher. A side effect list is a legal document. Reading it as a personalized risk profile is like using an aircraft safety card to calculate the probability of your specific flight ending in disaster. 47. The mental division between your recreational choices and your medical care feels clean and defensible. What you do on your own time is private, disclosing it risks judgment or consequences, and it probably does not affect the prescriptions you are being given. Recreational drug use is clinically relevant information that directly affects safe prescribing, anesthesia management, surgical risk calculation, and diagnostic accuracy. And its concealment causes measurable, documented patient harm. Cocaine and methamphetamine use significantly elevate cardiovascular risk during anesthesia and surgery, producing dangerous cardiac arrhythmias and hypertensive crises when combined with anesthetic agents. Anesthesiologists require this information to safely manage a patient through a procedure, and patients who conceal it create a clinical situation the anesthesia team is not equipped to navigate. MDMA use combined with serotonergic psychiatric medications, including selective serotonin reuptake inhibitors, monoamine oxidase inhibitors, and tramadol, creates meaningful serotonin syndrome risk, a drug interaction that is pharmacologically predictable and entirely avoidable if the clinician knows both sides of the equation. Cannabis use affects anesthetic requirements. Chronic heavy cannabis users typically require higher doses of anesthesia to achieve equivalent sedation and may have altered post-surgical pain responses. This finding is documented in peer-reviewed surgical literature and affects clinical management in ways that have direct consequences for patient comfort and recovery. Opioid use disorder affects pain management decisions in both directions. Baseline opioid tolerance means higher doses are required for adequate acute analgesia, while recovery considerations affect the entire post-procedure medication plan. Concealment leads to undertreated pain and missed intervention opportunities simultaneously. Most developed healthcare systems have explicit legal protections for patients who disclose substance use in clinical contexts. Information shared in medical consultation is protected by confidentiality and in most jurisdictions creates no mandatory reporting obligation for adult recreational use. Your doctor is not a law enforcement official. They are trying to keep the engine from failing during a repair, and they need to know what fuel has been running through it. 48 hours pass without clear improvement, and the conclusion arrives. This medication is wrong, it is not working, and the search for something better should begin. This self-assessment window is one of the most clinically consequential mismatches between patient expectation and pharmacological reality in medicine, applied across drug classes whose therapeutic timelines have nothing to do with 2 days. Most medications have timelines to clinical effect that are pharmacologically determined by the biology of the condition being treated, not by the patient's timeline preference. Antidepressants require 2 to 6 weeks. For methotrexate used in rheumatoid arthritis, one of the most effective disease-modifying drugs available for that condition, clinical benefit is typically not detectable for 6 to 12 weeks of consistent treatment. Premature discontinuation based on a short-term assessment is extremely common and leaves joint disease progressing without adequate control. Thyroid replacement therapy with levothyroxine requires 6 to 8 weeks to reach steady state and normalized thyroid function tests. Clinical symptoms, including fatigue, cognitive fog, and weight changes, may take months to fully resolve, even after laboratory values have stabilized. Topical antifungal treatment for nail infections requires months of consistent use because the drug must penetrate the nail structure as it grows, and nail growth is measured in months, not days. A 48-hour evaluation of antifungal therapy for a nail infection is irrelevant to the pharmacokinetics of the treatment by a margin so wide it is almost comedic. Community-acquired pneumonia treated with appropriate antibiotics may take 3 to 5 days to show meaningful clinical improvement. Abandoning treatment at 48 hours because fever has not fully resolved is a decision that can produce a very serious clinical consequence. The 48-hour window is your impatience imposed on a biological timeline. Most of the conditions your medication is treating were months in the making. The biology does not reverse in 2 days because you have decided that would be convenient. 49. The FDA approval process implies a transparency that most patients assume is comprehensive. Clinical trial data is submitted, reviewed, and the drug is approved or rejected. The information that exists in the literature is assumed to be the information that matters, and it is assumed to be available. Publication bias, the selective reporting of positive trial results and the systematic suppression of negative or null results, is one of the most thoroughly documented and consequential problems in biomedical science, with direct effects on prescribing decisions and patient safety that are not theoretical. A 2008 study published in the New England Journal of Medicine analyzed Food and Drug Administration trial data for antidepressants and found that 94% of positive trials were published, while only 14% of negative trials made it into print. The published evidence base that physicians, patients, and guideline writers relied upon dramatically overstated antidepressant efficacy because the unfavorable data was sitting unpublished in regulatory filing cabinets. Selective reporting of outcomes within trials, emphasizing favorable secondary results while downplaying unfavorable primary endpoints, was documented extensively in the Vioxx case. Data showing cardiovascular risk was available in the scientific record years before the drug was withdrawn from the global market in 2004. The All Trials campaign, launched in 2013, estimated that half of all clinical trials ever conducted globally have never been published, representing an enormous suppressed evidence base about drugs currently prescribed to patients. The European Union's Clinical Trials Register and the Food and Drug Administration's requirement for prospective trial registration on clinicaltrials.gov were introduced specifically to combat selective publication, though compliance and completeness remain imperfect. Ghostwriting, pharmaceutical companies authoring manuscripts and then recruiting academic researchers to sign them, has been documented and represents a form of publication bias in which the manufacturer controls the narrative while academic credibility is borrowed. The clinical trial literature your prescriber reads is a curated highlight reel. The footage where the drug lost is in a filing cabinet you are not permitted to open. 50. The prescription is written, the medication is in hand, and the implicit message received by a significant number of patients is that the pharmacological intervention is now handling the problem. Diet, exercise, stress. Those were the suggestions from before it was clear something clinical was happening. Now that the actual treatment is in play, the lifestyle variables feel like background noise the medication has rendered irrelevant. Medication manages a condition within a biological system that remains entirely shaped by what you eat, how you move, how much you sleep, and what other inputs you provide it. For most chronic conditions, medication without lifestyle modification produces substantially inferior outcomes compared to the combination. Metformin, the most widely prescribed type 2 diabetes medication, reduces hemoglobin A1C by approximately 1 to 1.5 percentage points, meaningful but limited. Intensive lifestyle intervention in the Diabetes Prevention Program trial reduced progression to diabetes by 58% compared to 31% for metformin alone. Statins reduce cardiovascular risk by approximately 25 to 35% in high-risk populations, but their absolute risk reduction is greatest in patients who are simultaneously optimizing diet, eliminating smoking, and exercising regularly. A patient on a statin who continues smoking gains a fraction of the maximum potential benefit. Antihypertensive medications control blood pressure within a diet physiology context. A patient on 2 blood pressure medications consuming a high sodium diet may still have uncontrolled blood pressure. Sodium reduction alone can produce an effect equivalent to adding a third drug. Antidepressants combined with regular aerobic exercise produce superior outcomes to medication alone across multiple meta-analyses. Exercise has an independent antidepressant mechanism involving neuroplasticity and HPA axis normalization. Acid reflux managed with proton pump inhibitors will return immediately upon discontinuation if the dietary patterns and eating behaviors that drive it remain unchanged. Medication is the scaffold. You still have to build the structure. The scaffold provides the platform. It does not do the construction. 51. A drug that has been in clinical use for 40 years carries the weight of longevity in a way that feels like comprehensive validation. Doctors have been prescribing this for decades. It has survived, which means it has been tested, which means it has been proven. Longevity is evidence of clinical utility. It means the drug worked well enough that it was not pulled and not replaced. It is not the same thing as a modern safety audit, and the distinction carries real clinical consequences that the age of the drug actively obscures. Digoxin has been used for heart failure and certain arrhythmias since 1785, more than 200 years of clinical use. A 2014 meta-analysis published in the European Heart Journal found a significant association between digoxin use and increased all-cause mortality in patients with atrial fibrillation without heart failure, prompting updated clinical guidance and a meaningful reassessment of its appropriate use. 2 centuries of prescription history did not prevent that finding. Phenobarbital has been used as an anti-epileptic since 1912 and has never completed a randomized controlled trial meeting current regulatory standards. It remains in use because seizure suppression is documented and removing it from practice is not feasible, not because it has been evaluated by any modern evidence framework. Warfarin has been used therapeutically since the 1950s, predating every standard of contemporary clinical trial design. Its narrow therapeutic index, drug interactions, dietary interactions, and monitoring requirements have been characterized over time. But its approval process belongs to a different era of evidence entirely. Colchicine, used for gout since ancient times from a plant employed in medieval medicine, received its first formal FDA approval through the modern pathway only in 2009, because no one had formally evaluated it by modern standards despite the centuries of use. Survivor bias does the rest. The dangerous old drugs were pulled, leaving only those that were useful enough to stay, which creates the illusion that survival equals safety. Longevity is not a modern safety audit. It is just a long run without being caught. If you want to see more, click the video on screen now.